So good afternoon, everyone, and thanks the chairperson as well as the organizer for involving me in this wonderful program. So in next 25 minutes or so, I will be discussing about. I will have the marathon task to include CNPC as well as CRPC. What is standard and then what is new and then what are the predictive markers. So I will really have to go fast. Uh, so we will not be discussing M0, CNPC or CRPC. We will be focusing in what is M1. And when we do that, the first thing that comes to my mind is what is oligometastatic prostate cancer and what is current status of oligometastatic prostate cancer in our treatment algorithm. Is it a hope or just a hype? And can we really cure some of these patients? So I'm going to talk about two parts in oligometastatic prostate cancer. First is to treat all metastatic sites, and second is to treat prostate primary in presence of metastatic disease. So if we look at the literature, this is an excellent article in 2019 in Cancer Treatment Review discussing various aspects of oligometastatic prostate cancer, and I have taken a couple of slides from this article. So how to define OMPC, and the definition is really varying as per the different authors and different articles. But classically, it is up to 3 or up to 5 metastases, and all metastases should be amenable to local treatment, and that local treatment most often is radiation. So how to diagnose this and oligometastatic prostate cancer? So traditionally in prostate cancer, we see that CT scan or MRI of pelvis and a bone scan is sufficient for staging workup. But when we really want to look at oligometastatic prostate cancer, all the contemporary literature wants to include newer generation of imaging and particularly PSMA PET CT scan to call it an oligometastatic prostate cancer. And on a PSMA PET CT scan, less than or equal to 5 metastases should be identified. Biology. So there is a strong conviction that localized disease versus widespread disease versus oligometastatic disease are having different biology, and oligometastatic disease is closer to localized disease as compared to widespread disease, and that's why that is being treated a little differently. But we don't have any biomarker to find out whether a disease is really localized or has a tendency of having a widespread disease. And what is the intention of treatment of oligometastatic prostate cancer? In I said that can we really cure some of these patients? And in 2019 Sam Gillen workshop, the question was asked to various experts regarding the treatment goals when recommending local treatment for all lesions in addition to systemic therapy in oligometastatic prostate cancer. So 69% of the panelists voted for prolongation of PFS and OS, and interestingly, only 14% voted for prolongation of PFS, 2% voted for prolongation of OS, and 4% only voted for disease cure. So even though we hope very few experts are really hoping for the cure of oligometastatic prostate cancer, and we only want to improve the survival. When considering prostate cancer to be oligometastatic, 48% panelists voted for a cutoff of 3 or fewer metastases, and 41% voted for cutoff of 5 or fewer metastases. So there is no clear consensus, and the art is evolving. I hope that in future we will be able to cure at least some of prostate cancer patients. So then that comes to the second part of this discussion, whether we should treat the primary in presence of metastatic castrate-naive prostate cancer. And there are two important trials, Stampede as well as HORED. And one trial, the data is pending. Piece one trial has given some of the data, but not about whether radiation should be given or not. So there is a stopgap data of Stampede and HORED data. It identified a 7% improvement in the 3-year-old survival. This is a very short interval, but then nonetheless there is 7% improvement among men. This is important, who had up to 4 bone metastases. So if the patient has widespread metastasis, there is no difference. But up to 4 metastases, if you are not a believer of treating all the sites of metastasis, uh, at least prostate, and that includes in piece one that include two arms in which a patient with HSPC received combination of regimen that included radiotherapy. To date, no randomized phase 3 trial has reported to use surgery for treating primary tumor in metastatic setting. So if radiation works to improve the survival, can we extrapolate and start doing surgery, as some of my surgical oncology friends are very fond of performing surgery in metastatic disease. But